when we are going to talk about celiac disease, the first thing is to increase the awareness of the disease. The disease is present among us, and worldwide the prevalence is more than 1%, including Africa as well. So we should think about it because many cases are misdiagnosed actually. To start by definition, it is chronic multi-organ autoimmune disease that affects the small bowel in genetically predisposed persons precipitated by ingestion of gluten. Gluten and gluten-related proteins are present in wheat and barley, and the ingestion of gliadin, an immunologically mediated inflammatory response occurs that damages the mucosa of the intestine, resulting in maldigestion, malabsorption of the food nutrients. في طبعا according to the European Society of Celiac Disease in 2019, they put these clinical syndromes which are related to gluten ingestion, including celiac disease, wheat allergy, non-celiac gluten sensitivity, dermatitis herpetiformis, and gluten ataxia. This can happen with positive serology without enteropathy. For the time being regarding COVID, this actually published in 2020, what to tell patient, no change in treatment with celiac disease in cases of COVID-19. This cartoon actually will give us the comparison between the three main disorders of wheat problems. Celiac disease, the time interval from gluten exposure to onset of symptoms can continue for weeks, while in sensitivity, hours to days, and wheat allergy, it is minutes to hours. And pathogenesis, autoimmunity, innate immunity, and allergic in wheat. Very important to know the HLA by genetic testing. It is HLA DQ2 and 8 only in celiac disease. So when you are in doubt about case of celiac, then the best negative protective value, which is 100% of having a negative HLA DQ2 and 8, which excludes celiac. The rest of the changes are present mainly in celiac disease and gluten, but not in wheat allergy. Diagnosis-wise, the main golden diagnostic tool is IgA, tissue transglutaminase 2 antibody, is the preferred single test for detection of Crohn's disease. You should know that total IgA if the test is negative, and we can replace it by diamine gliadin antibody or anti-tissue transglutaminase IgG. All diagnostic serological tests should be done while patient on a gluten-containing diet. Never do them in a patient with a gluten-free diet, because we will have false negative. The pathophysiology of celiac disease, generally, as we see here, the gliadin resists digestion in the duodenal lumen and may be directly toxic to the enterocytes. Undigested gliadin هيعمل cross into the intestinal submucosa, هيقابله tissue transglutaminase, which deaminates gliadin peptides. With this deaminated gliadin recognized by the HLA DQ2 and DQ8 molecule, stimulating an immune reaction. This immune reaction leading to activation of T helper 1 and 2, and this stimulates cytokines, stimulates CT8, natural killer cells, which cause apoptosis of the enterocytes, which stimulate later on the beta cells to differentiate into plasma cells that produce antibodies, anti-TTG and the anti-gliadin. And this interaction between the extracellular TTG and anti-TTG may cause further epithelial. This pathophysiology is very important because, as we'll see later, the novel therapeutic modalities are depending on this pathophysiology. So what are these novel therapeutic targets? The only treatment nowadays is gluten-free diet. but is associated with several possible challenges, including high economic and societal burden, inferior quality of life, and sometimes inadequate response. An increased understanding of the pathogenesis process in celiac disease has revealed various therapeutic targets for future drugs that could complement or replace a gluten-free diet. And novel therapeutic strategies include approaches to detoxify gluten already in the GI tract by sequestration or peptidase. Other investigational approaches comprise blocking intestinal epithelial permeability of the enzymatic activity of the TTG2, restoring immune tolerance to gluten or targeting the gluten-induced immune reactivation has also been investigated as possible therapeutic options, and the most advanced drug candidates have now entered phase 3 clinical trials. So again, this are the main sites of the action of the new drugs. For the time, we cannot go through them one by one. And these are the many trials, as we see here. Some of them are phase 2 and phase 1, and this one, which is the larazotide, is reaching phase 3 now, which causes blocking epithelial permeability and hindering gluten effect. The main, after talking about celiac disease, we should mention non-celiac gluten sensitivity, which is poorly understood until now, involves many triggers. This may be considered in patients with gluten-related intestinal or extra-intestinal complaints showing normal. In this case, we have normal intestine and normal serology. So, but the main manifestations and the extra-intestinal manifestations of celiac is present. So, it is excluded in subject failing to show symptomatic improvement after 6 weeks of gluten-free diet. So, the same management, which is gluten-free diet. What is gluten sensitivity? We can have adverse reaction to gluten or other wheat proteins, negative serology, a specific IgE, which is for wheat allergy, is negative here. Improvement with gluten-free diet, and we have extra-intestinal symptoms and signs, and ingestion evokes IBS-like symptoms, as we'll see later. So, but epidemiology is still undefined, but the papers or the research was done, and the prevalence ranges from 0.6 to 6%, depending on the clinical setting. As we see here, we call it a mixed bag of many potential culprits. As we see here, the wheat, it doesn't contain only gluten, but contains other materials which can induce the reaction, including fructans. Fructans, as we know, the food maps and their role in the irritable bowel syndrome. As we see here, this cartoon is very big and slightly complicated, but the main issue here to think about the effect on gut-brain axis finally, and giving IBS-like symptoms. There is another study which actually studied untreated non-celiac gluten sensitivity group with another group of untreated celiac disease, functional dyspepsia, and healthy carriers. And there, this study actually studied the neurons and mast cells and the spatial relation between neuronal fibrosis and mast cells and the distance which is closest to nerve. And finally, they found that non-celiac gluten sensitivity or celiac were diagnosed according to a well-defined workup. Symptoms were recorded according to modified G1 SRS severity 1 to 10, and functional dyspepsia was diagnosed according to Rome 3 criteria. This actually, again, discussing the mast cells and the closing neuronal immune interaction, which correlates with symptom severity in gluten and wheat sensitivity. The mast cells density correlate with the severity of bloating and abdominal pain. Percentage of mast cell close to nerves less than 5 micrometer correlate with the number of GI symptoms, and the percent of mast cells close to nerves correlate with the severity of bloating and abdominal pain. There are also associated autoimmune features. In 1/4 of cases, there is autoimmune thyroiditis, and also the correlation between antiparietal cell antibody positivity and presence of anemia. Putative markers, these are biomarkers under now trials to diagnose non-celiac gluten sensitivity, especially native anti-gliadin antibody and others, and collectively together can lead to correlate with the diagnosis of non-celiac gluten sensitivity. Also, they used confocal laser endomicroscopy in 108 patients of IBS challenged with wheat, milk, soy, yeast administered endoscopically in duodenal mucosa, and they found that about 61% reacted to wheat. They found also by confocal laser endoscopy that intraepithelial lymphocytes, claudin 2 or claudin versus negative tests, this giving eosinophilic degranulation positive. So as we see, there is a diagnostic challenge, relies on patient-reported symptoms after exclusion of other autoimmune disease. Salerno expert criteria for diagnosis of suspected non-celiac gluten sensitivity assess the clinical responsiveness to gluten-free diet, followed by a challenge test, reintroduction of gluten-induced controlled diet. Multiple challenges are present in this criteria, including unreliable for clinical practice, especially in pattern of gluten-free diet, risk of nocebo effect. Symptomatic improvement might be attributed to reduction of other foods, such as food maps. So there is a search for a biomarker or diagnostic histological lesion. Until now, there is no validated serological test or histological feature to diagnose non-celiac gluten sensitivity. Serum levels of fatty acid binding protein 2, soluble CD14, lipopolysaccharide binding protein, endotoxin core antibodies were increased and normalized after consuming a gluten-free diet. Some mucosal mast cell infiltration and the close within 15 micrometer to nerve proximity in the duodenum in non-celiac gluten sensitivity patients are features providing a histological basis to better understanding of GI symptoms in this condition. And this actually leads a further research to recommend it. So finally, the take-home message, celiac disease has shown an increased incidence worldwide. Celiac disease has not shown to increase the risk of COVID-19, except in patients with refractory celiac and on immunosuppressive, yet further studies are needed. An increased understanding of the pathogenic process in celiac disease has revealed various therapeutic targets to future drugs that could complement or replace a gluten-free diet. Non-celiac gluten sensitivity is a persistent disorder with GI and extra GI manifestations. Pathogenesis of non-celiac gluten sensitivity is still unclear, ongoing research. Diagnosis of the non-celiac gluten sensitivity is still challenging. The double-blind placebo trials require standardization, and search is needed for possible biomarkers. Thank you.